For example, if participants are not responding well to the intervention, provider may omit or modify or add the program content and activities. I'm not going to discuss the last one, program differentiation, because in many recent studies, researchers don't really focus on it, and often it is removed from those measurements blocks of fidelity. So why do we focus so much? Why do we need to focus so much on fidelity? Because it is really a foundation for our trustworthy research. Fidelity ensures that we can correctly interpret our results. It is synonymous of internal validity for me in this regard. And it shows us how to improve our program and training and helps to understand which parts of our intervention are actually working on or not working. And ultimately, it helps us learn how to bring effective programs into the real life setting. Uh, I came across this very interesting and useful tool, let's call it, guideline, developed by NIH Behavioral Change Consortium. And what they did, they developed this very nice comprehensive treatment fidelity framework. When I say treatment, it's equals to intervention, obviously, and it is tailored for health behavior change trials. And these best practice recommendations actually are put together as a guidelines for treatment fidelity across 5 domains, and it provides practical roadmap for us to ensure fidelity across the entire life cycle of the project, starting from study design, because fidelity obviously starts there at the planning phase, and we need clearly operationalize the intervention and map its critical components, theory-based components, those components that are responsible for delivering ultimate results. Let's call them active ingredients of the intervention. The next one is provider training. Training, and it's not seen as just one-time event, and it requires obviously standardization, specifically if you have multiple sites. You want your providers to be trained equally and receive equally, skills to then deliver intervention which would, act as a one common intervention. And training also includes ongoing boosting trainings, coaching, and other activities. The next is treatment delivery stage, and this is actually the action phase, maybe most challenging, most interesting, and we need to monitor adherence and competency, ideally using objective measures, and we will go deeper to discuss this, how fidelity actually can be measured. Then treatment receipt. Did our participants understand what we are telling them? I mean, did we deliver information in a way that most comfortable for them? This is a crucial check for the comprehension of our intervention. And last one, maybe also often overlooked, treatment enactment. Very often, our end point of measuring as a fidelity or clinical outcomes is knowledge and skills of our participants. But this last stage is critical, obviously. Did participants actually use new learned skills in a real life setting, skills or strategies in their real life? This is the ultimate goal of our intervention, obviously. And I have a couple, 2 or 3 slides, actually, screenshots from these guidelines that I just reviewed as an example for us to see what specific, very, very practice-oriented suggestions that are provided in this guideline. And study design, treatment fidelity related to the study design ensures that study adequately tests the hypothesis, the theory that we are actually that our research is based on, and the hypothesized activity ingredients of the treatment, uh, those ingredients that are actually hypothesized to affect our outcomes, are made explicit in our treatment protocols. This is very important, and it provides training and follow-up supervision for providers. And few examples here. Um, uh, Explicitly identify and use theoretical model as a basis for intervention. Or next one, pilot test the intervention. And then determine a priori number, length, and frequency of contacts, and so on. And the next one is develop plan for how you will be measuring fidelity. Methods for enhancing treatment fidelity at the training stage. Standardized training, specifically again, if you have multiple sites engaged in your training. Assess skills acquisition by your trainers. Okay, okay. Yeah, make sure that you prevent skill drift. So monitor the quality of delivery and plan for booster trainings when needed. So I will skip this. The same for treatment delivery. Very useful, practical tips. And then for treatment receipt. Let me skip this. So how do we measure fidelity, actually? And in this, uh, mm, actually, main message from this slide is that there is no one single gold standard to measure fidelity of our intervention. There is no perfect model, universal model. And we need to make strategic choice, balancing between quality and between what's practical and doable, given our resources and time. And this chart actually shows this trade-off. On a vertical axis, we have objectivity and rigor of different approaches to measure fidelity. And on a horizontal axis, we have resource and intensity or feasibility. As you can see, direct observations gives us the most objective data. You know, when you are present, when you observe, or when you do recording and then look at the recording, obviously this is most comprehensive and objective approach to measure fidelity, but it also most expensive and resource intensive. And very often we just don't have time and resources to do it. On the other hand, we have these self-reports, a very common universal fidelity checklist, you know, provider delivered session and then immediately fills this 10, you know, response to 10 questions and submits to research team. It's easy, extremely easy to collect, but it is the least objective approach to measure fidelity. There are also methods like document review and interviews. They fall somewhere in the middle because of this trade-off, a multi-method approach is often used and suggested to be used, which exactly fits into the specifics of our study. But I want to go a bit deeper into this measures of fidelity. This slide gives kind of closer look at the measurement toolkit. So each method has specific job and comes with own trade-offs. Checklists and self-reports, most common, easy to do, and can provide quantitative insight and can measure quantitative things like adherence and dose. But we have to be mindful about the quality and objectivity of the information that we collect. In this way, it can be biased. It can be biased. Social desirability and fidelity can be overestimated if only relying on self checklists by providers. Direct observation, gold standard, again, best for assessing the quality of delivery. It's high objective, but also very resource sensitive, and sometimes influence behaviors that we are trying to measure. And to understand why behind the numbers, we use interviews, focus groups, very informative, so they can provide deeper qualitative insight into reasons for adaptations or drifts from the protocol and reasons for low fidelity, for example, but they also require kind of significant amount of time and resources to collect data, both to collect and to analyze data. And finally, document review offers immediate, unobstructive way to get objective data on dose and exposure from existing records, like clinical records or study records, but often it lacks the context and often do not provide information on how this implementation was performed. So this is why we don't actually rely on any standalone single method to measure fidelity. It's always combination, and the critical thing is to keep balance between the quality of data that we are collecting and resource intensity and our ability to devote needed time and efforts to the data collection. So obviously, measuring fidelity is important and critical, but it's also important to acknowledge that it comes with its challenges, really, really critical challenges. And I mentioned an example of our study in which we just were unable to report it because we didn't know that we needed to plan in advance and we needed to, collect a lot of various data to measure it. We just overlooked fidelity in that study. So first step is defining core components of your intervention. And often researchers distinguish the core component, and also peripheral components of the intervention. So the core components, which are seen as non-changeable, those that are theory-based and responsible for your outcomes, but also peripherals that can be adopted and often must be adopted to the local context, to local needs, and so on and so on. Before you can measure fidelity, you have to be crystal clear which are those core components of your intervention in order not to amend them. Okay? And this is often not easy to do. Sometimes when there is a new intervention delivered and tested, you just don't have information which components are core and which are peripheral and can be modified and adapted. Okay. Second challenge, pattern of measurement, and we touched upon this as we discussed. The most rigorous gold standard methods often require often are most resource intensive and not doable just from the practical point of view. And the third challenge, lack of validated tools, how to measure fidelity in implementation studies. Most fidelity measures are specific to one particular intervention. They are homegrown, so you just invent. Sorry for that. So you often just invent them, and adapt them to your particular research. And then there is obviously lack of validation. And this might raise the questions about the reliability of the measures that we used in our implementation study to measure fidelity. And it's important to recognize these challenges and recognizing actually these challenges is first and most important step towards designing our fidelity plan and deciding what measures we will be using to measure fidelity in our study. And this brings us to a very important tension in implementation research and efforts, balance between fidelity and adaptation. I already mentioned core and adaptive components. So just to remind, fidelity can be seen as a sticking to the original program model to ensure it works as it was intended by its developers, okay? In the same time, adaptation is deliberate or unintentional modification of a program to fit local context, culture, or needs of specific population. And again, it's often needed, adaptation. So there is a dilemma. We know high fidelity is linked to better outcomes, and this is shown by many studies, yet adaptation often necessary for program fit, ownership, sustainability, all these are important elements. How do we balance these components? Again, solution is keep balance between core elements and adaptive periphery. Key is, but again, key challenge is to identify those core components of our interventions, those non-negotiable components of the program, and separate them from the adaptable periphery, elements that can be modified without compromising effectiveness of the intervention. To determine this balance, again, it's critical that evaluations be designed to collect implementation data, a lot of various data, examine types of modifications that we do over the implementation, the reasons for making those modifications. There might be very legit reasons for those modifications, and the impact that our modifications might have on the observed outcomes. This is critical challenge. My team never done it. We want to do it when we will have next implementation study, hopefully soon. But this is critical aspects of what we need to focus on when planning and doing the implementation study. So the key insight from this, adaptation is not a failure, obviously. It's often necessary step for success of our implementation study and implementation efforts. A couple of examples on adaptations, various types of adaptations, and they are done, I believe, in every implementation study. This is a slide from systematic review. Systematic review of 48, I believe, various evidence-based practices in HIV, mental health, substance use, and chronic disease. So as you can see here, provides look at how and why evidence-based programs were adopted in those studies that were reviewed. Key finding is that adaptations not just common, they are norm. Okay, and this review, systematic review, found that most frequent reasons for adapting a program are not to improve its fit with a specific culture. Are most often reasons are to improve its fit with culture, match the resources of the implementing organization, and to better meet the needs of target population. Okay. Another slide from the same systematic review. Now it shows the steps taken in the adaptation process across studies. So it can be piloting, it can be training of staff, meeting and consulting stakeholders, and so on and so on. And this systematic review and many other studies show substantial heterogeneity in methods for measuring intervention fidelity, specifically in complex healthcare implementation studies. Again, to summarize, observational methods like observing, videotaping, recording are and structural checklists, when paired with rigorous training and validation, are probably the best best solution. So multi-method, various methods, and balance between rigor and practicality. This is what I have for today as a solution to this challenge. Multi-methods, context-specific adaptations were described as increasingly common, but the field lacks consensus on standards and threshold. Another challenge. So there are very few standardized tools. Often we need to work and invent ourselves. So let's move, I think, yeah. But we started late, right? A bit. Some practical solutions for the fidelity assessment on this slide. And this suggests that we can use logic model, actually, before we begin our study, create clear logic models that maps our program's inputs, activities, outputs, and outcomes. And this makes our theory of change explicit and provides clear foundation for our fidelity measurement plan. Again, use pragmatic mix methods. Don't let perfect be the enemy of good. Combine less burdensome methods with inserting more rigorous ones. An example, use weekly self-report checklists for all sessions, to measure adherence and those, and have trained observers to rate, for example, 10 or 15% of sessions for quality assessment. Most important, be practical. You don't always need actually the gold standard measurement mix method to get a fuller picture with less burden. And the last one, plan for a systematically documented adaptations. Don't treat adaptations as failure. Plan for it. Use a simple framework or log to document your adaptations. What was adopted? Why it was adopted? Like for cultural fit, because of resource limitations, any other reasons? Who made those adaptations? At what stage those adaptations were made? And also, extremely important, what was the perceived impact of adaptation on your final observed outcomes? Okay. A simple example, just putting all together, let's imagine we are implementing school nutrition program, and the intervention is a 10 sessions curriculum designed to improve healthy eating habits delivered by teachers in the classroom. Okay, so this is our intervention. And our fidelity, what our fidelity plan can look like in this case, to measure adherence and dose. Simple teacher self-report can be enough, and also tracking 10 sessions. Okay, simple reports for tracking 10 sessions. And example of question, did you deliver session 5 this week? Yes, no. You know, this is just very simple example. To measure quality, you obviously need better data, and only self-reports might not be enough. You might want to do observation, but you cannot observe all the sessions. So randomly picking up 1 out of 10 or 2 out of 10 sessions delivered by teacher might be enough, and you get a full picture how the session was delivered, how the interaction went, what are the components to be improved, and so on and so on. Provides obviously more objective measures how well the content was delivered. And adaptations. Teacher might use a dedicated log to note any changes that they made. Okay. Example of such note: I used local fruits as example instead of ones in the book to make it more relevant for the students, right? Uh, to conclude, key takeaways. Fidelity is a cornerstone of rigorous implementation research. It is essential to interpret our results, to improve intervention, and also just advance the field of implementation science, Uh, adopt multidimensional, multi-method approach to measure fidelity. Understand different frameworks to choose those particular measurements that best fit your design and your resources. Okay? Balance between rigor and realities of your project, obviously. And just embrace tension between uh, 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 fidelity and adaptation. Goal is not just rigid adherence, but fidelity with adaptation. Proactively identify core components, keep them unchanged, but systematically track modifications to tell the entire or complete story of your implementation. That was it from my side. Thank you.
Thank you so much. We can take only one